We will go ahead and get started. Lori, if you're ready, go ahead and get started.
Hello, everybody. Thank you for taking time out of your busy day. I know we had a little technical difficulty getting this moving, but we'll be able to come to you through a recording. I'm happy to be talking to you today about transitioning the NICU baby from tiny trophic feedings and gavage feeds all the way to being competent to feeding at the breast. The only disclosures I have are that I am the clinical nurse specialist at Desert Regional Medical Center and that I also provide educational consultation for Medela. These are objectives that we're going to be going through today. And while we don't have time to cover all of the multitudes of the importance of milk, I wanted to at least start off with just a small reminder. Of course, we know human milk is very important for every baby, but especially these tiny premature babies, often born at little more than a pound. We know that this early colostrum and human milk will provide so many protective qualities to our babies. They're going to downregulate or decrease inflammation, which protects the neonatal gut from necrotizing enterocolitis, retinopathy of prematurity for the eyes, and helps the lungs to grow in a better state so that we can prevent chronic lung disease. Colostrum helps to grow the intestines and prepare them for the oral feeds that we're hoping to progress to. So as we talk about this topic today in the next hour, I'd like everybody to remember that we're taking again those tiny babies and progressing them day by day as we go along to be able to feed at the breast. And so as we know that we couldn't take that little baby on day 1 or day 2 of birth and put them at the breast and have success, we also know that we can't ignore some time at the breast and building this competence and then just expect for a month or 2 down the road to put the baby on the breast and be successful. We start with early trophic feeds to again engage the intestines, help them to grow, get ready for higher volume feeds. Oral care with colostrum could be an entire hour to speak about as well. The malt, galt, and OFOT systems are going to be triggered by having that milk in baby's mouth and helping the baby to progress from a passive immunity system to an active immunity. Colostrum is also going to help with gustatory development, the taste and smell of the baby. Of course, all of us love a great meal and they are pleasurable, and we want the same for the baby. And we're also going to be using non-nutritive sucking to, again, advance our baby as we come along to be able to learn to suck prior to the beginning of these oral feeds and breastfeeding. So if we're using a pacifier during gavage feeds or with oral care, this will help to, again, advance our baby and prepare them for the big day when they're ready to go to breast. We know that breastfeeding competence is not standardized for each baby at a certain gestational age. We can't look at a baby and say, hey, today you're 33 or 34 weeks and you're ready to breastfeed. You're ready to take feeds orally and be able to swallow and have all of that progression there. Every baby is an individual. Some babies have had very difficult courses, especially respiratory-wise. Some babies may be great and just do well and move along at a fast pace. Others may take time. But there is something that we as caregivers can do to influence their success, and that is early practices and continuing, as I mentioned, day by day to introduce the baby to new facets of breastfeeding. We also know that time at the breast from the beginning and as we move along will influence the antibodies present in the mom's milk. Time at the breast also helps to increase prolactin levels and produce more breast milk and protect mom's supply. And then we're going to talk a lot about skin to skin and the many benefits that it offers. We know that babies, as we mentioned, if we can start that skin to skin early, they're going to be comfortable and safe at the breast. We want to move from skin to skin to practicing, as I mentioned, that non-nutritive sucking. So usually somewhere around 28 weeks, babies are getting competent at that suck, but of course not the swallow and breathe portion of that. So we want to encourage non-nutritive sucking with feedings. And we want to begin the association of feeling full during a gavage with being at the breast. And this will ultimately lead us to infant-driven feeding or cue-based feeding. Again, establishing that early breastfeeding practice and moving into infant-driven feeding so that we can be more competent prior to discharge. And once baby is doing well at oral feedings at the breast, we're going to simply continue offering that breastfeeding. And as we move into the baby being able to control more of what they eat, not have a specified amount by the provider, they're going to just continue into what we call ad-lib feeding and become more competent. So oral feeding progression is dynamic. It not only changes day by day, but it can change hour by hour, and it is a very complex process. When we're working with these tiny babies, you can see that perhaps at 8 o'clock, it was time for the baby to be fed. And I can see that I'm assessing the baby's awake, has good tone, engaged, might be pulling hand to mouth or sucking on a pacifier I might offer, and things are great. Maybe at 11 o'clock, I come to do vital signs and interact with the baby, and the baby is tired, there's no tone, they're barely awake, or they fall asleep as soon as I get started. And I can know that the baby is communicating to me and telling me, now it's not the time for an oral feeding. Perhaps they've had an hour or two where they were struggling a little bit with breathing. Maybe their work of breathing was up. Maybe they had some apnea of bradycardia, and now it's more difficult for them to feed. That baby is communicating a message to me, and I have to be aware of the message and interact with that baby so that I can see right now it's not the time for safe, pleasurable feeding. I will let the baby tell me what we will be doing. So one thing I like to remind people of course, we know if a baby is born weeks and weeks early, maybe born 24, 25 weeks gestation, 15 or 16 weeks early, we are now responsible for the appropriate gestation of that baby. Of course, mama was doing her best, eating all the right things and getting her rest and taking good care of her baby. But once the baby is born prematurely, we have to continue that appropriate, thoughtful gestation outside of the womb. We have to establish a relationship with our baby, watch infant cues and readiness, and intervene appropriately. So as I mentioned, not only are we gestating out the womb, but we want to be aware of what would have been taking place inside the womb and progress that fetal progression appropriately outside. Again, establish a relationship with the baby and let the baby tell me what we are doing. We definitely know that experiences outside of the womb and in the NICU can definitely negatively impact our babies. Pain, noises that are loud, those noises would have been muffled inside, right? Complete touch, handling around the clock. These are all things that can contribute to brain mapping issues and decrease positive outcomes in our babies. So we want to be thoughtful and developmentally appropriate in everything we do. I mentioned that time at the breast, baby spending time with mom, even prior to being able to breastfeed, will definitely positively influence the milk that she produces. And a big piece of this with skin to skin is, again, the interaction of the baby with the mom. If you can imagine, when we leave the baby in the isolette, they may be lying on their stomach, their side, their back, but they are lying the entire time. Mom is outside the isolette. She may open the porthole, have her hand in there, be interacting on that level. But if we have her skin to skin with the baby upright on her chest and right here face to face, they're going to be able to interact more. Mom's going to be inhaling the germs, if you will, bacteria, virus that are in the environment of the baby. She might pick the hand up to give it a kiss or kiss the baby on the head as she puts the baby back into the isolate, a radiant warmer. And she takes those germs in. Her robust immune process will process those virus and bacteria, develop antibodies that are specific to those germs or problems that we want to take care of, right? Those antibodies are passed into mom's milk via the enteromammary pathway, and then mom has now developed specific tailor-made milk that is ready to positively influence her baby. If we don't have that time and skin to skin, we don't have those antibodies, and we desperately need them. We also mentioned that baby at the breast influences mom's breast milk production. So prolactin is one of the hormones that is responsible for making large quantities of milk and taking mom from that small amount of colostrum to more copious amounts of milk. That's called lectogenesis 2. And if we've got preterm delivered moms, we know that the breast tissue may be underdeveloped, especially if it's mom's first pregnancy, because this is the first time for her body to go through that. And it was cut short. We know that prolactin levels can be also diminished in moms who have had cesarean sections. While I know we're talking about very small babies now, they are also reduced in our moms who deliver late preterm infants. So even some of our moms that you might encounter whose babies were only born 4 or 5 weeks early, they may also go through this diminished prolactin level. In addition, other problems that mom may encounter, such as overweight and obese moms, diabetic moms, or moms that have had a postpartum hemorrhage, can also suffer from low prolactin levels. We definitely know that time in skin to skin and time at the breast helps mom's prolactin levels to increase, as well as her oxytocin, which is that wonderful hormone that not only releases milk, but gives mom a sensation of love and well-being. These are all improved, so we need to provide that skin to skin. Skin to skin will also provide that upright position, which is great for neuronal stimulation. It improves respiratory function. We know that these tiny babies, their chests are not well developed, the muscles are not strong, so their chests can be very weak. And being in that upright position, chest to chest with mom, provides stability. This reduces apnea bradycardia spells. It improves our oxygen saturation. So if you have staff that are concerned that baby's been having a lot of apnea and maybe we shouldn't take them out, maybe we should, because things will be better with mom. This time, skin to skin also provides olfactory stimulation for baby. We know that the amniotic fluid that baby was floating in and drinking before the baby was born preterm mimics and smells and tastes very much like the colostrum. So the earlier we're able to get baby on the breast, the baby will be having that sensation, that olfactory stimulation. And we definitely know that neonates have a very heightened sense of olfactory, of smell, because their eyesight is diminished and doesn't come along until later development. So again, engaging that sense will be positively influence our baby, and it will be getting baby ready for feeding. There's no worry about thermoreg, because we know that the breasts heat up to 2 degrees more than the temperature of the baby to keep the baby warm. So skin to skin will not be causing a baby to be cold. And additionally, we are now setting up mom and her breast and her chest area as a safe zone and a place of comfort. And this is not only for baby, but it's comforting for mom. So as we move along that continuum and start non-nutritive sucking at an empty breast and then infant-driven feeding or cue-based feeding, we're going to see that this has benefited our journey because the baby is already well established and comfortable at the breast. And I would like to remind people, and this is what I like to tell our staff as we talk about this, we need to think of skin to skin for our very tiny babies as breastfeeding. No, it's not breastfeeding in the way we think, but yet this is early breastfeeding behavior, and it contributes to the success as we move along. So we really want to establish this early. In California, our benchmarking group for all of our data for the NICUs is California Perinatal Quality Care Collaborative. They report nationally to the Vermont Oxford Network, which pretty much all NICUs across the nation funnel their information to. This, of course, helps to look at what people are doing, look at the outcomes of the babies, and establish best practice. So now there is a new audit question that is newly added, and that is, what was the first day that skin to skin occurred? We know, as we've already established, that this is more than something nice and just a nice, fluffy, feel-good intervention. It's drastically needed, and it's integral to the success of breastfeeding of our baby as the baby moves along and grows. So we now need to consider and make it the norm to use skin-to-skin care on our stable, ventilated babies. Instead of postponing until some point where someone feels it's appropriate, we need to start early. This can very easily be done with a standing transfer. I'm going to show you a video real quick. We always want to make sure that mom understands. We really would prefer for her to hold for at least an hour. So make sure she's eaten, been to the bathroom, doesn't have an appointment to get to. We use in our hospital 3 people, an RT and 2 nurses to help, of course, manage the endotracheal tube, get everything set up. One to kind of help mom and make sure she's steady while she's sitting down, and another nurse to handle the EKG leads and all of the IV tubing. So I'll show you this video. It comes from the University of San Francisco.
Skin to skin or kangaroo holding is an important part of your infant's care in the NICU. When you hold skin to skin, your baby is placed against your bare chest with a shirt or a blanket that completely covers both you and your baby. This video will show you how to transfer your baby, even with the breathing equipment like this baby has, from the incubator or bed to your bare chest while you are in a standing position. If your baby is on a ventilator, the staff will make sure all the tubing and lines are secure, and they will guide you through the process of transferring your baby to you. Remove your top and put on the hospital gown, turning it so it opens in the front, or you may use your own front opening shirt. This mother has decided to tuck her very small baby into her tank top. Remove all of your baby's clothing except for the diaper. Try to keep your baby nestled and tucked during the undressing. The respiratory therapist will work with your bedside nurse to ensure the ventilator is secure during the transfer. Your baby's nurse will be there to help and to get everything ready. Stand at the side of the incubator or crib. Lean over and bring your baby to your chest, placing your baby's head against you. Make sure your rocking chair is in a good position that makes it easy for you to lower into while holding your baby. Adjustments may be needed to secure the tubing and line. Your nurse can help tuck your baby into your shirt or gown, or with a warm blanket. You may kangaroo hold as long as you are both comfortable. Your baby's nurse may even offer gavage feedings or take your baby's vital signs during this time. Each time you kangaroo hold, you will feel increased confidence in caring for your newborn. You will be able to feel your baby's movements against your skin, and the baby will hear your heartbeat and find comfort in the skin-to-skin contact.
There is that little video. Okay, let's see if we can get this back. Well, let me see here. We can pull it right back. Something with that changeover. Stop that, but we will see if we can get back there quickly. Okay. Hope we're back up. Oh, we'll move along. Still having a little trouble. But you can see from that video that it's really not very difficult, and probably once your nurses and RTs get just a smidge comfortable with it, it's actually going to be easier than it was to get the baby all wrapped up in a blanket and take the baby out of the isolate and get it over to mom. Imagine also once we're carrying that baby over to mom, then you have to kind of flip the baby vertical to get the baby on mom. This is a much easier way to do it. It avoids some of that negative vestibular ear stimulation that we have going on. It's much more gentle, and mom enjoys being now in control of being able to pick up her own baby. One less thing that the nurse has to do for her. I'd like to share this. This is a friend that I made in the NICU while helping to care for her baby. The baby on the right was her first baby, Betito, and she has given me permission to use these pictures. You can see this lovely picture of him engaged in skin to skin. Mom is very comfortable and relaxed. Baby is engaging in that head control and starting to push and use some of his muscles. You can see that, again, environment being shared. So mom is able to smell and breathe in anything that Betito has there and make antibodies that he may need and push them out through the enteral mammary pathway into the milk. He, of course, is not ventilated here, but then on the left, you see Santiago, his baby brother. Santiago was born much earlier and had a much more difficult course, went on and off the ventilator several times, and you can see him here enjoying. This baby actually really started our journey with skin to skin because the nurses and everybody were very uncomfortable putting him on skin to skin because he had been so unstable. One day the RT came to grab me and said, "You have to help us. This mom has hardly held her baby." And so I helped them. We did this standing transfer. Mom was just in perfect control. The baby was happy. And it was just a pleasure because I said to the nurse as we were getting ready to have mom pick him up, I said, "Take a look at your audience." And you could see that everybody was lined up to watch what was going to happen. And it went off without a hitch. So we really want to promote that skin to skin early and often. As I mentioned, ventilated and stable. We're not talking about unstable babies, babies that are in your very, small baby protocol that we're worried about blood pressure and all kinds of things. We're talking about as the baby stabilizes. Get that baby out. Of course, mom is very important with that time at the breast being established as well as that enteral mammary pathway and the passing of those antibodies. Dad is very important too, so they can take turns. And we need to make it a priority with our nurses and our RT staff. So again, just educating all of the evidence-based information that points to why we need to do this. We empower our parents from the beginning. Our providers tell them that it's important for them to skin to skin. So we want to make this your unit norm and move forward. We also have a team approach to skin, so if for some reason one of the caretakers feels that it's not a good day to skin and the other does not agree, we take that decision to the provider so the nurse practitioner or the physician can help us make the best possible choice. So, in building this competence and knowledge with our staff, you want to definitely have a unit competency validation. We created a validation I'd be more than happy to share with people, and we began practicing in teams of 3 or 4. We like to have one of the staff people be the mom so they can really truly see how easy it is, and then just practice getting all of that together with the mannequin and a warmer or an isolette and practice that transfer. We continue this education and competency validation with all of our new staff. Our occupational therapist is involved as well, so it becomes an interdisciplinary skill. And as I said, this takes time and perseverance. You are always going to have people that aren't sure. You have people that are in the middle, and you have people that are just ready to go. So grab those positive people, help them pass the word, help them show how to do it, and just follow up on the naysayers, and soon you'll have a great culture of skin to skin. Oral care is another very important factor in the NICU. There's tons and tons of education and knowledge about this. Our unit has been providing oral care with colostrum since 2010, so it's definitely hardwired into our practice. We know that it helps to move immunity from passive to active, and that it can reduce ventilator-associated pneumonia or events. But we also know that that provision of colostrum directly into the mouth of the early baby helps, again, to provide that taste and smell, that gustatory development. And this, of course, is going to continue to progress your baby to actually being ready to receive oral feeding. Again, colostrum mimics that amniotic fluid, so we're continuing to provide the in utero experiences as the baby is out of the uterus. We want to pair that non-nutritive suck with the oral colostrum care, so we can use a pacifier during care. And so in our unit, as we know that it is highly protective and very important, any baby not able to take oral feeds, breast milk from the breast or the mouth, we are providing it via oral care. So this means all of our ventilated babies, any baby on respiratory support, our babies that might be nothing by mouth, NPO, or our gavage babies. And these are just two examples of how you can provide that colostrum. The top shows using a sponge applicator to dip into the colostrum and kind of rub and swab the mouth and the cheeks and the whole area. The bottom is what we really prefer, because if we drip, drip, drip very slowly, drop by drop, and get that to really bathe that oral cavity and a bit down the hypopharynx, this is what engages that O-fault system. So we use 0.2 mils that we give through an oral syringe. We work gently with the baby's natural sucking and oral movements to get that in. So again, we shared the evidence. We completed competency validations for RNs and RTs. We continue to do the same for all of our new staff. Of course, we do a double check process because this is Monarch milk. So if you have a scanning system or if you do a visual check with another nurse, and like we said, make it the norm, educate mom and dads love to do this so much, especially early on. It's about mom and pumping and all of these things. And dad doesn't always have the great things to do. So if mom is holding skin to skin, I have helped many a father to give those little drops. Sometimes I put my hand right on the back of his so that, you know, I can help him a little, or I just tell, go ahead and, you know, give another little drop. Do you see the baby likes it? Give a drop down here. Oh my gosh, how much are they enjoying this? And the mom and dad get to share that for together, and it's beautiful. We have created order sets for our providers, so this helps to standardize and make it super easy. They can just check that oral care for any of the babies that qualify, and it's ordered. So we mentioned that every exposure at the breast is building competence and a possible future success, right, for the oral feeding at the breast. So we really want to just have that day-by-day continued exposure. This, of course, helps to make things comfortable and good for mom and baby. And if we delay that exposure, don't have the baby on the breast for some time, mom can quite often get anxious and nervous about that. She may not want to try. So again, early and consistent. We want to move from that skin to skin and the oral care to the non-nutritive sucking at the breast, and then we're going to be progressing into infant-driven feeding. So here's a picture of a baby with non-nutritive sucking at an empty breast. You can see that the baby is very engaged, not old enough quite yet to be able to handle a bolus of milk in the mouth and swallowing and managing all that breathing and all. But this baby is able to start getting used to sucking at the breast, and again, building comfort with mom. So as we move into infant-driven feedings or cue-based feedings, we need to understand the reason for this. The old way of feeding in the NICU was that perhaps at a certain gestational age, the doctor would come along and say, we're going to try nipple feeds 1 time a day. Then you would progress to twice a day, maybe every other feed, and move along as the baby showed that they were able to do this. The problem with that is that the doctor has told me to pick a time to feed the baby, right? Oftentimes, I would pick a time that was surrounding the mother's visitation. So maybe mom is coming in at 2 o'clock in the afternoon and we decide that's the time to feed. However, baby may not be ready to feed. We talked already about partnering with our baby and watching their cues to tell us when they're ready to feed. So we want to do that by assessing the baby in an infant-driven feeding or cue-based manner. This will set up relationship-based care between the baby and the caregiver, the nurse, or the baby and the caregiver, the parent. We want to, again, as I mentioned, take our cues from baby and support the baby. I don't ever want to force a baby to eat who's not ready. That wouldn't be safe and it wouldn't be pleasant. And I never want to force a baby to finish the feed just because we started. So you need to have an established protocol for the nurses and everybody to work through. You want to definitely have a studied, validated tool that helps to determine your baby's readiness. And if the baby shows you that they're ready to try, why not start with breastfeeding? Breastfeeding is safe. Breastfeeding is what babies are made to do. And sometimes you'll have nurses who feel like, well, the first bottle should be given by me so I can assess. Or the first bottle, maybe the first several feedings should be bottled because it's safer. But none of these things are true. And all of these things can be assessed by the nurse with breastfeeding and not just with bottle feeding. So we'll follow those infant cues to tell us when to begin. Our protocol uses certain standards, especially for the respiratory stability of the baby. We're looking to have a baby that's behaviorally organized and engaged. Again, a sleepy baby is not going to be able to suck effectively, stay on the breast, or swallow safely. We look to use high-flow nasal cannula at 3 liters per minute or less. Yes, a baby with a high-flow nasal cannula can go to breast if they show, again, like I mentioned, that their tone is good and that they're engaged. We don't want a higher flow of over 3 because imagine what that high flow does. It supports respiratory breathing and function by stenting open or causing pressure right on the airway. If we have a flow of 4 or 5 or 6 and up, that airway is open and stented. So imagine how difficult that's going to be for baby to close the trachea off with the glottis, right? And swallow and get it to go down the esophagus and not into the trachea because that whole area is stented open. We also want to see 25% oxygen or less. If our babies are needing much more than that, it's going to really take up a lot of calories and potentially increase their work of breathing. And we look for a steady weight gain at least 3 days of 15 grams per kilo per day. This is because if your baby is barely gaining any weight on gavage feeds, once we ask them to, be orally feeding and using a little more calories and effort, they may not be gaining weight. So that is what we do. Generally established, most babies develop that suck, swallow, breathe ability somewhere between 32 and 34 weeks. And so our institute just decided to go in the middle and choose 33 weeks. So once you have a baby that meets those needs according to your protocol, we begin scoring. We're always going to score at least for 24 hours because we want to see ongoing how the baby's going to react. If we're looking at the scoring and maybe I only had one time where the baby actually scored a 1 or 2, which is that alert, maybe fussy prior to cares, or at least becoming alert once we handle the baby, having good tone, having some of those rooting or feeding cues going on. If that only happened one time in 24 hours, probably not quite ready. So we'll continue to score till we get at least 50% for a day, and then we start to move into infantry and feeding. As we're scoring our babies, if we do have a score that's in that red zone 3, 4, 5, this is really not a baby who's engaged. The baby's not going to be able to stay on the breast and continue a feeding, and it may not be safe because their tone may be off or they may already be a little compromised. So we won't feed a baby that scores 3, 4, or 5. Once we've decided that this is a good time to put the baby to breast, we will continue to assess the baby during the entire feeding, and we're going to look for the baby to be a 1, a 2, maybe a 3, hopefully strong coordinated suck, swallow, breathing. Of course, the very first few feedings or first days of feeding, this may not be consistent, but as the baby has more practice, more time, and continues to mature, they're going to show you that they have this nippling with a strong coordinated suck, swallow, breathe throughout the feeding. So if we see that a baby is not showing these qualities, if they get to be weak and consistent, have vital signs that are out of the parameters or just are not looking good, that baby is then telling me, I gave you 5 minutes or 10 minutes of time, and now I'm tired and it's time to stop. So again, according to that relationship-based care, I am going to understand the baby, and I am going to stop that feeding. Since we're still developing competence at this, the physician has probably ordered a minimum amount of feeding, so I am just going to gavage the remainder of what is left. Now you might ask, since the baby is at breast, how do I know how much to gavage? And this will often be a barrier from some of your nurses who don't necessarily want to start breastfeeding prior to bottle feeding. This is a validated system and a tool that we can use to reliably tell us how much the baby needs. I don't have to see it visually with my eyes, and I no longer have to take a pre and post weight, which takes time. And again, some of the function of the baby, the time for that baby to be engaged in feeding, I can use this scoring tool because somebody has already done the work. So if my baby is scoring in the top two, a 1 through 5, so remember that could be maybe your baby's first time, maybe they didn't really do so well, they were only a 4 or 5, maybe they did great, they were only on the breast 0 to 5 minutes, you're gonna gavage the entire feed, and then you can see as we go up in quality and in minutes at the breast, that amount of gavage gets smaller and smaller, all the way to no gavage for a high quality feed over 15 minutes. So some of the disadvantages that we know that we will see, again, with our very prematurely born infants are that even though they're growing and getting bigger, they still have long sleep periods with very short wake periods. They can tire easily. They can become overstimulated and shut down. And then this kind of shows, hey, I'm done, right? And I'm going to listen to that. They can show that they have a weak suck. We definitely know that the muscles of the oral facial area and the muscle tone is low. They're still developing, so they're not going to have the best suck. Again, they're going to get better and better. We've talked about some of the respiratory disadvantages. We know for sure that, like we said, these babies are still growing. The chest isn't really developed yet, and they don't have great tone. So keeping the airway open can be a challenge. We just want to make sure that our baby is in good alignment, head to neck to shoulders, head not tilted too far forward or too far back to close off the airway. Keep that nice and open. We know that they will be uncoordinated, and guess what? They would have been uncoordinated with a bottle too, so we can put them to the breast. And one thing we definitely know is there may be a disproportion from mom to baby. Mom may have a very large breast and a very large areola and nipple. Baby's got a tiny mouth, but we have nipple shields, and we're able to use that to kind of fix that disproportion. This will also keep your baby in a nice deep latch, which makes sure that the milk is flowing and that we've got better attention. We do know that the infant's intraoral vacuum at breastfeeding is what is used to remove milk versus just a tongue compression with pushing the tongue up to kind of trap the nipple between the mouth and get the milk out. Infants are made and designed to breastfeed, and therefore they use vacuum. So while we mentioned our preterm babies may not have great oral muscles, around the mouth and not that great suck yet, they will be able to generate that vacuum over time. So we want to encourage breastfeeding. Again, as I mentioned, a nipple shield will help the baby to stay on and will improve some of that vacuum. And then this, of course, will improve that transfer to baby and protect mom's milk supply. So we definitely want to consider position of the baby. As we mentioned, there's that positional airway obstruction. So we just want to make sure that everything is aligned. Airway collapse can occur. That's going to cut your feeding short. And we want the mom to really be able to see the latch so that she can ensure that all is going well. Therefore, traditional cradle hold is really not the best position for these babies. Cross cradle is going to be much preferred. This again gives that great control of the body from the head to the neck to the trunk. This also aligns the position that we use when we're bottle feeding babies in the NICU, which is a modified side lying position. We know that modified side lying improves the ability of the baby to swallow, the whole swallow response. It's just perfect alignment for the bolus of milk to be transferred to the baby's mouth and then swallowed. This also provides a similar position if we're using cross cradle And then the modified sideline, so on the times when mom is not able to breastfeed, we'll be able to have it similarly set up. So this shows a nice depiction of that cross cradle. Mom has her left hand that's free to be able to control her breast, make sure that it's not too heavy, resting on the baby. You can see that there's a small roll under the baby's neck, and mom is able to use her right hand to keep baby in alignment, and then also keep the baby on the breast, and there's great visualization of that latch. And then from the front, you can also see how well that's going. This is an example of that modified sideline position. It also mimics greatly, that cross cradle. And even just looking at this, you can kind of see how easy that would be for baby to swallow that bolus of milk. Another hold that you can use will be the upright hold. This also provides, again, mom a really good look at that latch. She can make sure that baby is deeply latched on, and it may be easier to keep, again, that sleepy baby on the areola and nipple because this has baby deeply latched, which means every suction motion that baby gives is going to be providing milk to the baby, which keeps the baby awake. You just have to be careful that you're not allowing the baby to slouch down over time. Keep them nice and upright. So that picture we saw earlier is also a nice upright position. The picture on the right, of course, is a much older baby, but it gives you a good idea of that alignment. And then one last thing that can really help, especially our early babies, low-tone babies. This might be a baby with a congenital issue or Down syndrome. The dancer hand position can help mom to not only control the weight of her breast and how far that's into the mouth, but also allow the mom to give just a little slight cheek support, which can help baby's vacuum that they're creating. So she wants to make sure, again, keep the weight of the breast off the baby's face. You use the pointer finger to the pinky. The middle finger to the pinky to support the breast, and then the pointer finger and the thumb to make a U to cup under the baby's cheek. So you can see here again, great latch view. Baby can really look at mom, and she's got that thumb and forefinger gently providing some of that cheek support to be able to keep that suction going. You do want to be sure, especially if you look at the bottom, you can see how that finger curves under the baby's chin, not to put too much pressure because that might inhibit baby swallow. And lastly, a very deep latch, again, keeping that flow going, baby on and baby awake to have a successful feed. So again, all of these things can take some time and some perseverance, but the more we engage providers and staff, the better it will be. Make sure that those policies and protocols are already ready to roll, that you've had input from your bedside caregivers as well as your providers and your leadership to make sure that they're well thought out. Any supplies you need, like perhaps the oral syringes or the little sponge applicators for the milk are there. No excuses not to roll this out. We want to, as I said, engage our family, empower the parents to be involved, start early, set it as the norm so that if you have a parent who encounters somebody who doesn't really want to provide oral care or skin to skin, they can question. So these are all positive things. And of course, right from the very beginning, starting that talk. If you have pre-admission consultations, neo-consults, provider updates, the doctor comes by, they can be checking, we can ask them, how is skin to skin going? How is your pumping going? Are you getting enough milk so that you can provide oral care? These are all positive influences, and we all know that the family loves and trusts the bedside staff, and they also very greatly consider what the physician has to say or your nurse practitioner. So make sure that verbiage continues, consistent, shift to shift, and day to day. Offer printed information to back up what we tell people, in conversation. And I just love Paula Meyer has established long ago, she's one of my breastfeeding heroes, right? Does all of the research on human milk and breastfeeding in the NICU and all of those wonderful things, that milk should be considered a medication. And the doctors at her hospital at Rush in Chicago say to the parents, These are all the things that we can do to help your baby, but I can't do the best job if I don't have your milk. And that puts a great consideration on the mom, and she should be very happy to know that she's a huge part of that care team. So remind and support that. I'd like to thank you. I again apologize for some of our technical difficulties. This is my work email that's there. I know that Medela will be able to take, I would assume, if there might be some questions that might come to me. Again, just get in there and make it happen. Be excited. This is definitely something that's just in my heart and so precious to watch. And I love to see the growth in our units as we get moms and babies together ready for the breast. Thank you.